tonight's Insight Talk. Tonight you are here for traumatic brain injury with Akutue. So Akutue, over to you.
Hi, my name is Akuziwe. I'm currently doing a DPhil at the University of Oxford with Balliol College. But by background, I'm a medical doctor and I'm currently a neurosurgery trainee. So today I'm going to give you a talk on traumatic brain injury, which is something that I'm partly studying in my DPhil. I'm going to tell you a bit about myself because I have an interesting story in medicine. I'm from Zimbabwe, which is a country in Southern Africa. I was born and raised there. Did my primary and secondary school there, and I started developing an interest in the neurosciences and medicine around this time through biology lessons. And I attended one of Inside Talks like these during my high school years, which got me interested in the neurosciences, which is why I'm so excited to give this talk to you guys. So I finished my A levels, and then in 2016, then I moved to South Africa, which is just about a 2 hour flight from where I grew up, but different country. And I did medical school there for 6 years at the University of the Witwatersrand, which is in Johannesburg, about central South Africa. Then at the end of med school in 2022, I got the Rhodes Scholarship, which is an international scholarship program for leadership development and postgrad studies at the University of Oxford. And so I moved to the UK last year in September to pursue what I'm currently studying now, a DPhil in clinical neurosciences, as part of the Balliol College and the Nuffield Department of Clinical Neurosciences. So today I am going to give you a talk on traumatic brain injuries, as I said before. And one of the most important things to understand whenever studying any condition associated with the brain in medicine, in neurosurgery in general, is to have an appreciation of the anatomy, that is the structure of the brain and the surrounding structures. So I'm going to give a brief talk on that. And I think it was part of the worksheet that I sent to you last year to work on prior to this talk. Then I'm going to go over traumatic brain injuries, what it actually is, and the mechanism of traumatic brain injury, what causes them, how we diagnose them in the clinical space, and finally, we're going to go over how they're treated and how they're prevented. So there is quite a lot of you in today's talk. So I suggest that we just go over what I have in the slides now. And if you have any questions on any section as I'm talking, just take a note of it on a piece of paper. And then at the end, just after the mini quiz, we will discuss questions that you have. Right. So if we take this year is Jada Pinkett Smith. She is an American celebrity. And I chose a picture of her because when you look at any person, this is what you see. But we know that the brain is housed within this organ. So if we remove the outer layer, that is the skin, this is what we'll see. And what we appreciate on this head profile is that the face is covered with muscles which are responsible for facial expression, movement, and things like chewing. The head is covered with muscle basically everywhere except the central section here, where we have nothing but something like a connective tissue layer when we remove the skin. So basically, the cranium is partially covered by muscle only on the front part here, and on the back part, and partially at the sides. So if we were to take a cross section at this area of the head where we don't have muscle, what we find is that that part is covered by the scalp. And the scalp is basically skin and underlying subcutaneous tissue covering part of the skull called the cranium. It's composed of 5 layers, and there's a nice memory device for you to remember what these layers are. So it's the memory device is SCALP. So the uppermost and the outermost layer is the skin, and the skin is composed of hair follicles and sebaceous glands. And then underneath the skin, we have a connective tissue, a dense type of connective tissue, which is basically fibers and cells. And within this, we have many blood vessels that are tightly adherent to that connective tissue. And it's for this reason that if you get a skull laceration, you tend to bleed a lot, because that dense connective tissue has a lot of blood vessels. And then underneath, we have a layer called the aponeurosis, or the aponeurotic layer. And this is like it's like a tendon. If you know tendons from any other parts of the body, they're responsible for connecting muscle. They're responsible for connecting muscle to bone. So that aponeurotic layer, it connects these the muscles. I don't know if you can see where I'm pointing at. Okay, so the muscle at the front here, which is called the frontalis, and the muscle at the back here, which is called the occipitalis. It connects these muscles to the cranium. And then underneath the aponeurotic layer, we have another type of connective tissue, but this one is a loose type connective tissue called loose areolar connective tissue. This one it also has blood vessels, but it's got a special types of blood vessels called emissary veins. So an emissary is basically like a delegate connecting one place to another. So, and what emissary veins are, they connect that outside loose connective tissue, then cross through the skull, and then they connect with the venous system inside the skull. So this is a danger area in that if you get an infection, in that part of the skull, it has the potential to cross those emissary veins to affect what's inside the skull, that is the brain and other substances. And then underneath the loose connective tissue, we have the pericranium, which is a membranous tissue directly covering and hugging the cranium. So we have now removed the scalp. We're now at the level of the skull, and we can appreciate what the skull looks like from different angles at this on this picture. What we can see is that we have a bottom half, which is the half which supports the face. That is the muscles of facial expression and other structures that form the face. And then we have the top half, which houses and protects the brain. And that's the one that we're interested in today's talk. It's the part that's called, it's the part that's called the cranium. The skull, including both the face part and the cranium, is composed of a total of 22 bones, of which 8 of them are in the cranium and the other 14 are in the facial part. On this picture, we can appreciate these squiggly lines dividing the skull into different mapped areas. So it divides the bones of these squiggly lines are called sutures. They divide the bones of the skull, they join them, and in an adult skull, they are fused. But if we're to look at a child's skull, these sutures are initially not fused, and that's important because when a child is born, their brain is about 340 grams in weight, but an adult's brain is about 1,500 grams. That is 1.5 kg. So we have a lot of substantial development from infancy to adulthood. What actually happens is that when a child, in the first 2 years of life, the child's brain grows about 3 times size from that when a child is born. So it grows to about 80% the size of an adult brain, which is why it's important for the skull to be able to expand and grow, and these sutures help to do that. If we look at what's on the right-hand side here, which is the which is the skull of a child, we see that we have this diamond-shaped area not covered by any bone and a triangular one here where our sutures meet. We see that so it's just covered by a membranous sort of layer. These are called fontanelles, and if you've ever seen the head of a child, you can appreciate particularly the anterior fontanelle. So why they are important, another importance of having these open sutures in a child is during the birth process. So the head has to pass through a narrow birth canal. So these sutures and these fontanelles enable the skull bones to overlap and then bounce back to normal size after birth to enable the head to pass successfully through the birth canal during the birth process. Okay, on to the cranium. So we said that the cranium has got 8 bones. So it's actually got 6 kinds of bones, but 2 of them are paired, which means that we have a total of 8. So on the left-hand side here, what's highlighted is the roof of, it's the top of the cranium, and then on the right-hand side, we have what we'd get if we were to take a cross section here, and we get the base of the cranium. So we have the roof on the left-hand side and the base on the right-hand side. And the bones that we have here, we have the blue one, that's the frontal bone. The green one, that's the parietal bone. The one at the bottom here and at the back, that's the one in orange, that's the occipital bone. And then on the base, again, we have the occipital bone, the green parietal bone here, and then we have the temporal bones here. And the temporal bones, they house the ear canals. Then we have the badge-like shaped, the one with the wings here, which is the sphenoidal bone. Then the small little one here, which is the ethmoid bone. And again, we have the frontal bone. And what we can see on the base of the skull is this large opening here, which is what's called a foramen magnum. And it's where the brain, okay, not quite the brain, it's where we have the division between what's the brain and what's the spinal cord. So it's where we have a continuation from the brain to the spinal cord. Okay, so if we peel off the cranial layer, we see that we have this layer of membranes which surrounds the brain. This layer of membranes is called the meninges, and if you've ever had a condition called meningitis, that's a condition that's a condition where we have an infection of these membranes here. So the membranes surrounding the brain, they're made up of 3 parts. So we have the outermost layer, which is tough, and it's the dura mater. The dura mater is, we can think of it as 2 parts. We have one which is tightly connected to the inside of the cranium, And then we have another part that's closer to the brain side. So the space that's between that outer layer and that inner layer of the dura mater, it's called the extradural space or epidural space. So extra means outside and epi means above. So hence extra or epidural space. And then we have a middle layer of the meninges, and that's called the arachnoid mater. And then, so the space between the dura and the arachnoid mater, that's called the subarachnoid space. Sub means under, so subarachnoid would be under the arachnoid. And then the last layer of the meninges is the pia mater. And the pia mater is the one that's closest to the brain, and it actually follows the grooves and the folds of the brain. So the space that's between the arachnoid and the pia mater is called the subarachnoid space because it's beneath the arachnoid. Right, and on to the actual brain itself. So we can appreciate from these images what the brain would look like if our skulls and our skin and our scalps were transparent. The brain has three major parts. It has more, but in today's talk, we're just going to discuss the three major parts. So we have the largest part, which is the cerebrum. And then we have a smaller part, the cerebellum, which literally means small brain. And then we have another part called the brainstem, where our brain then goes on to connect with our spinal cord. So the large part, the cerebrum, is composed of two parts, the right and the left hemispheres. And I'm sure you've probably heard about the right side controlling the left side of the body and the left side controlling the right side of the body of the cerebrum. So these two parts, they're not quite, well, they're separated by a layer of the inner part of the dura mater in between, but they are connected by this structure called the corpus callosum, which has nerve fibers connecting the two. And the cerebrum is composed of four lobes, which are named for the bone that they are most closest to. So we have the frontal lobe, which is underneath the frontal bone. And this one is responsible for what we call higher functions. So personality, decision making, basically making wise decisions, logical reasoning, things like that. It's also responsible for movement and things like that, and partially for language as well. So about language, we have this concept of dominance, which side is dominant, and most people are left dominant, and the dominance of a side is basically determined by which side predominantly controls language functions. So the frontal lobe on the dominant side would be partially responsible for language. And then we have, in yellow here, we have the parietal lobe, which is responsible for one sensation stuff, and secondly, it's responsible for visual spatial recognition. So basically, if you have two pins pricking you at your hand, you are able to recognize that there are two instead of one because of integration of the information at this center. And then at the side, we have the temporal lobe, and the temporal lobe is responsible for memory. It's responsible for language. If we're on the dominant side of the brain, it's responsible for hearing as well. Then at the back, we have the occipital lobe, which is responsible for vision. And then, so that's the cerebrum. We also have the cerebellum, which is underneath the cerebrum. This one is responsible for movement patterns, so coordination, learning movement. Yes, it's responsible for those functions. And also correction of movements. So people who have injuries in this area, you find that they have this staggering form of walking, they get tremors, they can't quite pinpoint and do fine functions when they can't quite pinpoint what they want to do and basically work on things. And then we have, finally, we have the brainstem, which is composed of the uppermost part, which is the midbrain, and then the mid part, which is the pons, which means bridge. So it's a bridge which connects fibers from the cerebellum with fibers from the cerebrum. And then we have the medulla oblongata, which is where the brain then continues on into the spinal cord. Now, the medulla or medulla oblongata it's important for many vital functions. That is, functions which are necessary for survival. These include breathing patterns, controlling your heart rate, controlling your blood pressure. The brainstem itself is responsible for controlling and coordinating reflexes, most of which are protective, like your gag reflex, which prevents you from getting food down the wrong pipe when swallowing, down the trachea instead of the esophagus. Then it's also responsible for what we call cranial nerves, which are basically nerves responsible for functions of structures above the neck. So we can appreciate on this diagram that we have sort of empty spaces, these dark areas where the brain isn't quite in contact with the skull, but these spaces aren't empty. They have this important fluid called cerebrospinal fluid, and this fluid is made in the brain from blood plasma. It's made in the brain from blood plasma and circulates around specialized cavities called the ventricles, and as well as the subarachnoid space, where it's then reabsorbed into the circulatory system. This fluid has a protective function, and it also provides also has a buoyant effect. Remember, the adult brain is 1.5 kgs, which is, whilst it's small, it's relatively, it could be relatively heavy on the cranium. But because of cerebrospinal fluid, the effective mass of the brain is like 25 grams. So it holds up the brain, making it lighter on the cranial structures. So if we take a closer look, at the brain, we find that it's made of two types of cells. We have the neurons, which are the nerve cells responsible for making up the signals that are responsible for the functions that we discussed earlier. And we have the glial cells, which are responsible for supporting the neurons. So they provide nutrition, they protect the neurons. So the neuron has the cell body here, which we find in the outermost part of the brain, called the gray matter. And then it has the axon, which then projects down into the white matter, the inner layers of the brain. And then the glial cells, we mostly find them also in the white matter of the brain. There are about billions of these cells in each human brain. Then the final point on the anatomy of the brain, we can't talk about the brain without talking about its blood supply. It's one of the most it's one of the most metabolically active organs in the body. Whilst it's relatively light, it's only 2% of the it's only 2% of a person's weight, but it's responsible for taking up about 20% of the total cardiac output at any time. So it has a rich blood supply, which is important because of all the functions the brain is responsible for, and is also quite sensitive to deprivation of oxygen and other substances. So it has to be well vascularized. So the blood supply comes from branches of the aorta. We have the internal carotid artery and the vertebral arteries coming in to form this, at the base of the brain, a collateral supply called the circle of Willis, basically to ensure that if one vessel is blocked, we have backup. Again, like I said, very important that the brain is well supplied. And then we have the venous drainage, draining blood from the brain back to the heart via a venous system draining into the internal jugular vein, which then goes into the superior vena cava into the right atrium. Right, and then now going on into the subject of today's talk, traumatic brain injuries. So traumatic brain injuries are important because they are a leading cause of death in people under 45 years of age in the developing world. We have about 27 to 69 million cases of traumatic brain injuries happening per year. They're responsible for loss of health and loss of income, disability in many people, which is why they're a very important topic to understand and appreciate. So what they are really, if we're to break down this term, we have two things that are important for us to define whether we have a traumatic brain injury. One, we have to have trauma, which is an external force acting on bodily tissues. And secondly, we should have brain injury. So brain injury could be something that we can actually see at the structural level, that is anatomical injury, or it could just be an alteration in the function of the brain without an actual injury that we see. As long as there is evidence that the brain has been injured, we would say that that's a brain injury. And it's important to understand that the brain injury part, because you can have a head injury without having a brain injury, in which case we wouldn't say that that's a traumatic brain injury. So in summary, a traumatic brain injury is an anatomical or functional damage to the brain as a result of an external force. Okay, there are several mechanisms of traumatic brain injury. One, we can have the traumatic brain injuries can happen as a result of direct impact, which we call core injuries. So this can happen as a result of an external object, an external object applying force on the brain via the skull. And this can be things like flying objects, like a ball in this case, or in the cases of interpersonal violence, like knives, sharp objects, sharp penetrating objects, bats, and even animal hooves and things like that. And then direct impact can also happen as a result of the head accelerating onto a stationary object, like what's happening to this person here. So at the site of the injury, we have what's called a coup injury. And then in cases, we also have cases where we may not have a direct impact, but we have acceleration or deceleration of the head. These can result in traumatic brain injury, as in the case of car accidents or a very tragic form of child abuse called shaken baby syndrome. So basically what happens here is that if your head accelerates in one direction, you have a sort of inertia of the brain moving in that same direction. So it hits against the skull, causing an injury in the opposite direction of the acceleration. And then it can also happen as a result of deceleration, rapid stopping. The brain, as a result of inertia, it's still moving in that same direction and hits against the skull. So we can coup and counter coup injuries can occur concomitantly, as in this picture here, where you have a direct impact, getting a coup injury on one side, on the side of the direct impact, and a counter coup on the other side. And then finally, we have TBIs as a result of blast wave injuries, as can happen in cases of combat. There are many causes of TBIs, the leading cause being falls, followed by road traffic accidents and being struck by or against an object, as we talked about, like flying balls, flying objects, and things like that. Can also happen due to assault, interpersonal injuries, and many other causes that are not listed here. So when a person comes in and we suspect a traumatic brain injury, we ask a series of questions to determine whether this could be a TBI or just an isolated head injury. So we ask what happened, was there history of that trauma? And secondly, are there symptoms that could indicate that there's an alteration in brain function? So did they lose consciousness when this happened? Did they lose memory, or did they lose a function of the brain that could point us to where on the brain the injury happened? And then we have this important tool called the Glasgow Coma Skull, the GCS, where we test the patient's response to eye opening, whether they can open them spontaneously like I'm doing now, or if they can't do it at all, whether they can talk coherently or they can't do it at all, and whether they can move their limbs in response to instructions or pain, whether they can't do that at all. So this scale helps us to classify the severity of the traumatic brain injury. So we have mild traumatic brain injury, where the score would be between 13 to 15. 15 is the highest that anyone can score. And then we have moderate, where the score would be between 9 and 12. And then we have mild traumatic brain injuries, where the score is between 3 and 8. So the lowest anyone can score would be 3. And then once we determine that there could be a traumatic brain injury, we want to know which area of the brain was affected and what type it is. So we can do a series of scan, something called a CT scan. And this one is like a series of X-rays that gives us cross-sectional slices of the brain, and sort of giving us a 3D structure of the brain. Then we can also do an MRI scan. So this one works by by mechanism of magnetism. I'm not actually 100% sure of how it really works. That's not my area of study, but it also gives us cross-sectional slices of the brain and can help us localize where the injury happened. So the types of traumatic brain injury that we can have are, we can have a concussion, which is characterized by loss of consciousness or loss of memory, that is amnesia after the trauma, which is quite temporary. And in concussion, we can't actually see a structural change on the brain, but we do have evidence of functional change, like the loss of consciousness and the amnesia. And this one, it happens a lot in children and young adults. And then we also have contusions, which happen mostly as a result of the coup and contre-coup injuries. Contusion is a bruise on the brain substance. Then we can get hemorrhages, intracranial hemorrhages, and they are named for where they are. So, which is why I spent quite a bit of time discussing those spaces between the meningeal layers. So we can have epidural or extradural hematomas. A hematoma is basically just a collection of blood. So whether we say hematoma, hemorrhage, it really means the same thing. Then we can have a subdural hematoma. We can have a subarachnoid hemorrhage, and then we can have an intracerebral hemorrhage, which is a hemorrhage within the brain substance itself. And then we can have an intraventricular hemorrhage, which is hemorrhage into those ventricular cavities, which normally have cerebrospinal fluid. Then we can also have cerebral edema. Edema is swelling of tissue as a result of accumulation of fluid in it. So in traumatic brain injuries, we have a change in the function of blood vessels, which means that they become more leaky, and then we get leakage of more fluid into the brain substance, causing swelling, which is very problematic because the adult skull can't expand. So we now have this increasing brain mass in a very limited space. And I will go on later. I will discuss later why this is a problem. And then on the other end, we have this condition called diffuse axonal injury, which is basically shearing of the axons of your nerve cells as a result of the traumatic brain injury, which can happen in coup contre coup injuries. And this is quite bad. The patients tend to have comas and basically unconsciousness and long-term disability. So traumatic brain injury is an issue for one of the reasons is that it causes direct damage on the brain, and that changes the function of that area affected. So if the frontal lobe is affected, that can cause changes in higher functions like personality, is what happened in the case of, I don't know if you've heard about Phineas Gage, a person who got this penetrating injury into their brain. They survived, but they had an massive alteration in personality. If you have an injury to the brainstem, that can actually cause death, because remember, your medulla oblongata is responsible for your vital functions, respiration, and cardiovascular function. If your cerebellum is injured, alterations in coordination, occipital lobe, alteration in your vision, temporal, alteration in your memory. So direct damage to the area of the brain affected. And then the second problem is, think of a balloon. If you blow into it, the skin of the balloon can expand to accommodate that increase in volume. But the skull is more like this container here. It can't expand, particularly the adult skull. So this guy here on the right top corner of the slide, Alexander Monro, he was one of the researchers who came up with the conception that the brain, the intracranial volume, so the volume inside the skull, is constant. That is, majority of it is the brain, and then equal parts blood and cerebrospinal fluid. So this is kept in an equilibrium, that can be affected by additions to that volume. So in traumatic brain injury, if you get that hematoma that has a mass effect in the brain, it starts pushing, it starts competing for space in that limited intracranial space. So the cerebrospinal fluid initially gets displaced to try and make space for this mass, as well as venous blood. And initially, the pressure inside the head is all right, but as the mass increases, we now have less and less compensatory reserve, and the intracranial pressure the pressure inside the head becomes elevated, which is an issue because it now starts pushing against the brain, a condition which we call herniation, and this is the worst case scenario. It can directly result in death, particularly if your medulla is pushed down. This is pushed down that if you remember the foramen magnum, because medulla are responsible for your vital function. Even without all that herniation, an elevated pressure is an issue because we have this concept of cerebral perfusion pressure. So for your cells, your neurons to be for your neurons to get nutrition from the blood, the plasma has to filter out of the blood vessels. So we have two forces acting. We've got blood pressure from the blood vessels, and then we've got the intracranial pressure acting against the blood vessels. So the pressure for perfusion would be the difference between these two. So you can see how if we have an increase in the intracranial pressure, you would have a without a compensatory increase in the blood pressure, you would have a reduction in the perfusion pressure of the brain. And this is the area that I'm studying in my PhD. Then we also have long-term problems. If you've watched Concussion, a movie starring Will Smith, you see that people with traumatic brain injuries in the long term, they can get psychological problems like concentration issues. They have issues with headaches. They can get convulsions. They can get long-term disability, issues with bladder control, bowel control, issues with communication, and they can also be prone to infections, especially if their brain injury was associated with an open head, with a fracture of the skull, because an infection can move from the outside to the inside of the brain. So treating traumatic brain injuries depends really on what type of traumatic brain injury it is, how severe it is, and also the profile of the patient, how old they are. So medicine is basically a balance of whether whenever we're looking at a treatment modality, we look at whether it's likely to cause more good than harm. So we can treat it conservatively, which is for mild traumatic brain injuries that can suffice. So following up the patient if they need nothing really, or we can treat it with medication, We have to make sure that their heart is well supported, so blood pressure is within the normal range. And a good way, another more conservative way of treating traumatic brain injuries, just to elevate the head, and this just lowers the risk of the pressure in the head, lowers the risk of increasing the intracranial pressure. We also have to make sure that the glucose is in the normal range, because remember, the brain is sensitive to deprivation, that your respiratory system is functioning well, and if they need it, you can put them on a ventilator. Can also use medication, and the medication that we use is mainly to control the intracranial pressure. So we can use hypertonic fluid solutions to try and shift fluid. So things like a highly concentrated form of sodium chloride solution called mannitol, among other things. Then we also can use surgery, and surgery is to monitor the intracranial pressure, as in this here, where we place a pressure probe inside the head. And surgery is also for controlling the intracranial pressure, sometimes by tapping out some of the cerebrospinal fluid, or what we have here at the bottom, which is something called craniectomy, which is literally removing a part of the skull to allow the brain to expand, to increase area for expansion in order to try and control the pressure. Or another surgery that we do is that of removing mass lesions, so like taking out brain bleeds. And this is a picture of me. I was in the first surgery that I ever assisted in. I was in my 4th year of medical school in South Africa, and I was assisting on a surgery to remove a subdural hematoma. Another important part of treating traumatic brain injury is rehabilitation. We use many kinds of healthcare practitioners for this: doctors, nurses, physiotherapists, occupational therapists, psychologists, psychiatrists. They're all important in the long-term management of traumatic brain injury. And then for prevention of traumatic brain injury, we have to look at two-pronged approach. One, preventing the trauma from happening in the first place. So we can do this by preventing falls, preventing road traffic accidents. Just refer to our causes of traumatic brain injuries. Alcohol and drug control, measures to reduce interpersonal violence. And then we can also prevent brain injury in the case that trauma happens. So a very effective way would be using helmets. Helmets are like a second skull, and they are 37% effective in reducing fatalities in the case of traffic accidents. And overall, they are 67% effective in preventing brain injuries. And things like seatbelts also help. Okay, so we've come to the end of our talk. I've got a mini quiz here, and I would like you to attempt answering the first question. So just write down the answer in the chat box if you can. So we've got Mr. Smith, who was involved in a motor vehicle accident and now has lost fine motor skills. Which part of his brain was affected? Okay, I see many of you have said C. That's correct. The cerebellum is involved with balance and coordination. Okay, so the second one, to assess whether a person who had a fall possibly has a traumatic brain injury, which of the following is the most useful piece of information? Great. I see most of you said, all of you in fact, have said D. Yeah, the length of time of unconsciousness, gaps in memories, change in behavior. It's the most useful sign. The other ones really, they could affect the clinical course, but they don't really tell us whether the person had a traumatic brain injury. Where does a subarachnoid hemorrhage occur? Good. So a subarachnoid hemorrhage, under, so it would be underneath the arachnoid. So that would be between the arachnoid and the pia mater D. Okay, and to assess severity of TBI, an important tool that is commonly used is the Yes, so it's the Glasgow Coma Scale. It tells us the severity of TBI. The other things that we have here, particularly the MRI and the CT scan, they help us in assessing other things like what type of injury we have, but severity, we rely on the GCS. Okay, damage occurring on the opposite side of the brain where the brain has bounced back and impacted the skull is known as the Yes, the counter-coup injury. Okay, that was the last question of the quiz, and we have a few minutes. So if you have any questions from today's talk, I really hope this talk was helpful. I'm very keen to answer any questions to the best of my ability if you have any from what we discussed today. See, there's a question here. I can't see the chart. Okay, thank you. Can sleeping in certain positions affect the brain? Well, in normal, in people with no underlying conditions, that shouldn't affect the brain in any way, because remember we have these protective structures around the brain that prevent the skull, the cerebrospinal fluid, the meninges, that prevent the brain from getting injured from just any small kind of trauma. It's the more extreme kinds of trauma that would cause injury. So in people with normal brains, that shouldn't be an issue. Could you remind me what course you two have taken? I would like to do more research into it. Okay. So I'm not sure I understand this question. Well, for my undergraduate, I did Bachelor of Medicine and Bachelor of Surgery, which is a medical degree. Then, yeah, and with that, you become a medical doctor. But right now at Oxford, I'm doing a PhD, or as they call it in Oxford, a DPhil. I'm doing a DPhil in clinical neurosciences in a topic of neurosurgery. So I'm studying children with who are at risk of increased intracranial pressure. So some of them have traumatic brain injuries, but others have brain tumors, others have skull conditions. And I'm basically trying to evaluate ways of measuring the pressure in the brain. How great an impact does the site of trauma on the skull have on its severity? So the impact would depend on one, what type of Yeah, what type of instrument is causing the impact, whether it's a penetrating or a blunt object. And secondly, whether the person has underlying conditions. So a person with a normal skull versus a person with an abnormal skull, such as people with bone conditions like osteoporosis, cancers would be would need different levels of trauma to get the same kind of injury. So, but generally, the higher the trauma, the more likely you're going to get a severe injury. How does the blood-brain barrier actually exclude certain substances from entering the brain's supply, the brain's blood supply? Okay, so what the blood-brain, sorry, the blood-brain barrier is, it's not quite a physical barrier, but more like how the brain capillaries and the blood vessels, how they regulate and prevent certain substances from entering the brain. So if you remember when we talked about the cerebrospinal fluid, we said that that's formed from blood plasma, but it doesn't have the same composition as blood plasma because that's adjusted and regulated. So it's, well, simple answer would be it's the structure of the brain capillaries that would prevent certain substances and also regulate the concentration of ions and molecules in the brain. I'm not sure if that answers your question. So not a physical barrier, but structure of blood capillaries. What was your most interesting case involving TBIs? I'm going to, well, for this one, I'm going to have to say my first one, just because I was very excited about that one. It was the first surgery that I assisted in. Yeah, it was just a person who had an elderly person who had a fall, and then they got a traumatic brain injury, a subdural hemorrhage. And because I was doing an elective at the hospital, I got to assist. I was working in South Africa, and in South Africa, unfortunately, most of the cases of traumatic brain injuries are due to assault and interpersonal violence. So it was good to have something a bit different, a traumatic brain injury due to a fall. Jack, is the time up?
Well, we've got 1 minute, so I think if there's one last question you would think would be quite nice to end on, we'll end on that question, and then anyone who's asked a question but we haven't had a chance to answer tonight, you will get the answers to it. Akudziwe has very kindly agreed that she will answer all the questions. She'll write them over basically to me, and I'll send them all to you. Her answers by email, so you get a follow-up email with the recording of this talk, and all the questions that have been asked will be answered as well. So. Yeah. So yeah, if you want to pick one last question to end on, I think that would be really nice.
Okay, I'll take the meningitis question because it's quite simple. It's antibiotics. Yeah. So in most cases, you give intravenous antibiotics. And then, well, first, there's a two-pronged approach. Meningitis is associated with an increase in intracranial pressure. So you can do a spinal tap, which is inserting a needle, a cannula through the back to try and tap out some of the fluid to reduce the pressure, and then you add antibiotics to treat the bacteria that caused it. But if it's meningitis due to other organisms like viruses or fungi, you use antimicrobials that are targeted to that organisms. Just said antibiotics because it's mostly bacteria.
That's brilliant. Thank you so much, Kudue. It's been really interesting listening, and clearly, there was a lot of interest from the audience because you've got so many questions that we haven't been able to answer. Thank you all very much for attending. Thank you for the quality of your questions. Like I say, we will get round to answering them all, so don't feel like you've been left out in the cold. We will answer them. And yeah, that is it from us. So again, thank you so much, Kudue. And like I said to everyone, you will get a copy of this recording and the answers to your questions in a few days once we've got around to being able to upload it and stuff. But yeah, brilliant. Thank you so much, everyone. Have a lovely evening. That's all from us. Bye.
Bye.